Good morning, everyone. At the outset, I'm very grateful to Dr. Srinivas for all and he had done for me, re-imbibing to me, in me the interest into the subject. And really, after going through all the years and doing the ENGs, and really the VNG which we have now is really awesome. And yeah, today I'll be presenting on this topic on downbeat nystagmus. See, downbeat nystagmus has been described way back around 1940s and all. So before that, we always understand that most pathology in the vestibular system would give rise to a horizontal kind nystagmus, and the vertical nystagmus was very, very rare. And even in the early medical literature, they would describe it as a rare phenomena. And it was only in 1945 that authors like O'Brien, Bender, and Gorman, they have come up with these, they find about these vertical nystagmus occurring in up gaze and in central gaze, whereas they would consider them to be as congenital and rarely acquired disorder. And there was always a debate that whether they really were they are not lesion confined to cerebellum, or whether and some authors believe that they were associated with lesion in the cerebellum or in the brainstem. And authors like Barron and McAlpine, they even said that these kind of nystagmus are of no diagnostic values. It was only in 1954 that Cogan and Barron, they had described in 9 patients with Arnold Cherry malformation, and they have shown that all of them had vertical nystagmus. And then on in 1968, he went and published about downbeat nystagmus, their characteristics, the cause, and the localization. But at the same time, during those years, there were all the animal studies which have been done, where they deliberately cause lesion in the brainstem and the cerebellum, and showing the presence of downbeat nystagmus when there are lesions in the floccular nodule lobe of the cerebellum. So I'll just be presenting a couple of cases here which we have encountered in our practice. There's a 50-year-old gentleman who was admitted through an emergency with a headache and dizziness for 2 days, associated with nausea and blurring of vision. His vertigo was, you would say, positional associated, which increased in any sudden change of posture. Neurological examination, he had hyperreflexia. Tandem walking was positive, and his Romberg's was negative. He was found to be hypertensive. He was known also to be hypertensive, but he was not on any medication. And our investigation showed that he also had dyslipidemia. There's a clip here showing only the spontaneous eye movement in the dark. Unfortunately, with this case, this was taken on the second day of this thing, because on the first day I was having OT. So even here you can appreciate the vertical downbeating nystagmus, though it's a very low intensity. But yeah, if compared to the first day, you could just look at his eyes and you could see the beat. But yeah, on the second day it has decreased a bit. The Dix-Hall-Pike, on doing Dix-Hall-Pike test, it could elicit horizontal geotrophic nystagmus on both sides, on left and right sides. So this patient was subjected to an MRI study which showed small vessel ischemic changes in the periventricular area. So we treated him on the line of mild stroke with hypertension and dyslipidemia. He was subsequently followed up. The medication for stroke was continued, but then his vertigo was better. No more nystagmus elicited in his follow-up, and he's on treatment for stroke. Now this other gentleman, he's a 30-year-old male, admitted again in a medical ward with tingling sensation all over the body, with recurrent attack of seizures. He's also a chronic alcoholic. So when he was admitted, he was stabilized anti-epileptics were given, and we had done a CT scan, which showed evidence of a neurocysticercosis. The next day, he was again done an MRI, which confirms the lesion of neurocysticercosis, with almost the similar findings and what's been described in CT scan. After 5 days of admission, patients start developing giddiness and difficulty in moving. So on examination, on clinical examination, patient had severe ataxia. He could barely move. You would see him just like a log. He was sleeping. He wouldn't dare turn to the other side. He wouldn't dare turn his head. Somehow he managed to do his VNG and record. And practically in this gentleman, you could see all kind of, nystagmus. He had downbeat nystagmus. He had alternate beating nystagmus, which were purely if you correlate this ataxia and the kind of eye movement you see, you know the lesion would be somewhere in the cerebellum. Something was affecting the cerebellum. If you see his autokinetic tracing, he could not do it at all. He was not able to do the pendular tracking. So radiologically, we had neurocysticercosis. The other causes of this could be any cause of cerebral ataxia. It could have been it could have been just an eptoin toxicity. So on consultation with a neurologist, he said that eptoin can cause severe ataxia. With even a single dose of eptoin, you can get a severe truncal ataxia. So one was that possibility, because he developed the giddiness and all the ataxia just 5 days after the initiation of anti-epileptics. So it could have been alcohol intoxication, which you would get similar kind of findings here again, or it was some sort of vitamin deficiency. It could be vitamin B1, B12, B6, because he was an alcoholic also. Now this is another interesting case, and I would acknowledge Dr. Zulfikar Hazarika, who works in the other hospital with me in Shillong there. So we share the same interests, and we do generally consult these cases when we have difficulties. So this was one of the cases which he got. So this is a 46-year-old female. She had visited the OPD with persistent giddiness for 3 months duration. It's momentary and was also positional associated. She didn't have any other risk factors, and clinical workup did not show anything much, did not reveal anything. ENT examination was normal, and all on VNG, when you did the other tests were okay, normal, psychiatric, the pursuit, normal, but then on doing the Dix-Hallpike test, this is what we get. It had the latency, and it's, as you see, it's a purely downbeating nystagmus. On MRI, it showed cerebral small vessel disease. This was just doing a simple MRI, the thing which we generally ENT centers just send a MRI scan. So subsequently, this patient was, since he had a downbeating nystagmus, we could not correlate to any peripheral lesion. So an MRI showed cerebral. We sent to was sent to a neurological center where a complete stroke workup was done. And eventually, they had repeated the CT scan with the diffusion perfusion imaging scan, and there it was shown that she had even some plaques in the cerebellum. So she was finally treated on line of stroke. And this is another case, a 47-year-old female, came with again history of persistent giddiness of 2 months. Here again, we did not elicit anything clinically, and on examination, this is quite interesting if you see this case, on Dix-Hallpike, on the right side Dix-Hallpike, just notice there's a latency period, and you would notice that on the right Dix-Hallpike test, you get a torsional nystagmus. And then wait for a few seconds, the torsional reduces, and then patient go on to develop a purely downbeating nystagmus. So maybe this is the case where I would like to get more inputs from the experts around here. You have you do a Dix Hallpike, you get a nice torsional nystagmus suggesting of a posterior canal, and suddenly after a few seconds, he goes on to develop a purely downbeating nystagmus. And then this patient was again followed up after a couple of weeks, and the Dix Hallpike, she was better, but she still had the giddiness, and repeated Dix Hallpike again, and the patient still has persisting downbeating nystagmus, but of course of a lower intensity if you compare to the first Dix Hallpike test. So it's a low intensity one, but yeah, but it's still persisting. We did an MRI. So MRI showed a right temporal horn dilatation. So from our clinical basis, what thing we have a few differential diagnoses. One would be a multi-canal BPPV. Whether the temporal lobe dilatation was important in this case, or whether it's significant in relation to her chronic giddiness, because temporal lobe dilatation can suggest a temporal lobe epilepsy or medial temporal lobe epilepsy, or else an early Alzheimer's. Early Alzheimer's would not expect a vertigo, but yet in seizures we may have giddiness, and but it's not correlating with what these findings we're getting in the Dix Hallpike test. So from previous papers which have been published in as a cause or localization of downbeating nystagmus, these are a few disorders we've been shown: infarction, infection, vitamin deficiency, neoplasms, which all involve the cerebellum. And the sign symptom would be giddiness, diplopia, oscillopsias, dysarthria, slurring of speech, blurring vision. And what generally we have to correlate with these signs when we are looking at downbeating nystagmus. The reason I'll tell you in the next slide. We have to look for these symptoms, at the same time you'll have to look at the gait. Like we have the gait ataxia, we have to look at the speech, the limbs ataxia, and any presence of hemiparesis. If we're trying to localize, generally we would look at the brain, the cerebellum, the brain stem. So generally, if we are looking for cerebellar dysfunction, we look for the scanning speech, gait ataxia, limb ataxia, or else any evidence of incoordinated eye movement, like you get that in internuclear ophthalmoplegia, or any limitation in the movement of the up gaze or down gaze. That would suggest either the lesion would be in the pons or in the midbrain. Now, these are a few characteristics which you would get in a nystagmus, and the reason why I told you that you have to be aware of the other central examinations, because if you're looking at the characteristic of nystagmus, they have been all described. Effect of nystagmus on horizontal gaze. They say when it has been published that when you're looking at this horizontal gaze, your downbeat nystagmus become more prominent as compared to your central gaze. Your frequencies or the amplitude of this nystagmus on your horizontal gaze, they would increase. You would have a different patterns in your vertical gaze. It could be a constant velocity. It could be increasing or decreasing velocities. You may have it will increase with your on convergence. You may be able to elicit in positional tests, but none of these tests, none of these characteristics would really tell you where exactly is the lesion. It cannot localize the lesions. So that is why you have to correlate the eye movement along with the clinical sign and symptoms again, and again the importance of history taking comes into play. And imaging, how important is imaging these down gaze? I would say it's very important. And MRI would be more superior to CT scan, because here you can study the structures more better. And what can be missed, like in demyelination disease, like or infarction disease, you may catch up better with MRI scans, and developmental anomalies are much more better visualized in MRIs. Now, how does this happen? Slightly, we cannot go into the detail of it, but just brush through of what are the mechanism in downbeating nystagmus. It is basically what happened here is a imbalance in the tonic vestibular innervation in a downbeat. You see that, like Dr. Srinivas today has just briefed in the morning, that the vestibular nucleus is a deep nucleus of the cerebellum. So practically any disease of the cerebellum would remove the inhibitory factor or inhibition of the of the vestibular nucleus, which practically leaves the anterior canal innervation practically uninhabited, and causing an upward eye movement and compensation, giving you a downbeating nystagmus. In an article which was published by Arnold Brownstein, he had compared in his, this is about positional nystagmus, positional downbeat nystagmus. So he had seen about 50 positional nystagmus, and then they're going to describe positional downbeat nystagmus in a central nervous system disease, and those who do not have evidence of central nervous system disease. So what he's seen that what they have, he describes that firstly in a downbeat nystagmus with CNS disease. So they are all almost all are cerebellum related, and he went on to define that probably we have a floccular lesion. Cerebral floccular lesion. These are studies which were correlated with some study in mice where they where they deliberately caused a lesion in the flocculus or the nodular lesion. So those who had downbeat nystagmus, which are constant downbeating nystagmus, so they would correlate with the with lesion in the flocculus, and those who had transient were correlated to the nodular lesion in the cerebellum. And secondly, that you can get downbeating nystagmus in multiple system atrophy, like in all the Parkinson's disease. So Parkinson's disease also has the typical and atypical. So by getting a downbeat nystagmus, it also can help in differentiate in the different kinds of Parkinsonian syndrome. And then you went on to describe the downbeat nystagmus when there was no evidence of central nervous system. So the other, what you can get here is any involvement or BPPV of the anterior canal, which is practically very rare to occur in the anterior canal, because one of the position of the anterior canal will not allow the particle, to stay to circulating. It will obviously drop down by nature, self-clearing, okay? So, but then they're getting it. So the persistent downbeating, why is it, they've given why it causes downbeating nystagmus in an anterior canal, or why do you get anterior canal BPPV? The reason one is unknown, or maybe there is a conglomerate of the debris which are too large to clear, or there may be continuous production of debris in the, falling into the anterior canal, or a failure of the disaggregation on a narrow common crest. And because of the vertical position, so the theory of cupulolithiasis is more viable to the anterior canal. So, but then the problem is that when you have cupulolithiasis, you will not have adaptation or habituation when you're doing the maneuvers. But you can see that in certain cases of anterior canal BPV, you still can have canal lithiasis. So again, it's a bit controversial here. As to how apparent is the torsional nystagmus, he went on to say that probably you will get a torsional nystagmus, but the torsion part is so minimal and it gets overwhelmed by the downbeat nystagmus, so you tend to miss. So this is where sometimes, doing a VNG and having a closer look at VNG, because we had cases where we had downbeating, about 1 or 2 odd cases we had with downbeating, but then if you closely look, they had a torsional component, and those torsional components are really, really very minuscule if you compare to the downbeating component. And the torsional component is, he described that it is much smaller in anterior as compared to the posterior, probably related to the position or the angulation of the canal, of the anterior canal in corresponding to the posterior canal when they are aligned along sagittal plane. So these are what they have mentioned about the mechanism and the differentiation between. So what is the take-home message? So when take-home message is practically is that when you have a vertical downbeat nystagmus, it's almost always central, and you would always correlate these kind of nystagmus to any cerebral disease. Do you need to do an MRI? I feel that, yeah, it's a mandatory to do a MRI. And as ENT surgeon, we would always send just MRI brain. Okay, so, but from our past experience, we feel that, okay, after consultation neurologist, that when we send an MRI, it's always send a complete scan, like a diffusion, because small infarcts, if you're just doing an MRI, which, the radiologist, when you send an MRI, they just do an MRI. But when you send with a diffusion scan, so they will be able to take even a minute infarct, which could be responsible for the problem. And whether anterior canal can cause vertical nystagmus, yes, it can cause, but the possibility is there, but it's rare. So with that, I would like to conclude. Thank you. Yes, sir.
My concern is cerebral small vessel disease is a very common problem, very commonly reported on MRI.
Yes, sir.
To blame downbeat nystagmus on it, unless until there is an acute infarct in the flocculonodular lobe or somewhere else, it is difficult to explain. Second, and sir will explain that case. Second, I have quite a number of cases of downbeat nystagmus where MRI and every other investigation is perfectly normal, but you get downbeat nystagmus on left disc sulpike, right disc sulpike, as well as straight head hanging, but they do not respond to any, at least in my hands, they have not responded. Your comments, sir. Third, responded to various maneuvers for particle repositioning maneuvers. Third, dependent funda, that posterior canal is common and anterior canal cannot occur because it is vertical. Anterior, see, if dependent is the point, then you have that ampullary, and that is most dependent of the posterior canal, not the common cross. So if dependent funda is there, then the particles should go to the short arm of the posterior canal and should behave as posterior canal cupulolithiasis in majority of the cases, which does not occur. They behave as canalolithiasis. That means they come through the common cross. And that is why the attacks are very common when patient gets up in the morning. They enter through, if they can enter into the posterior canal, if the sleeping habits permit, they can also go into the anterior canal, number one. And second, when they come in the anterior canal, again it has two parts. If they are in the posterior limb, they will fall immediately through the common cross. If they are anterior, in the anterior limb, anterior half, they will tend to go towards the cupula until patient again lies in those positions which can favor the spontaneous resolution. So this dependent funda is, I think, it is not working. Then, I think, another thing. If you have even a hint of, this is what literature says, if you have even a hint of torsional segment, torsional component with downbeat, that means it is most likely the torsional component will show you the inner ear involved for downbeat nystagmus. That most likely is anterior canal BPPV. Sir should give these expert comments, or if you will like.
Thank you very much for your very exciting and interesting cases. Just I have few comments. First, the case presented for a lady with a small vessel disease with downbeating nystagmus on left or right dexhol bike. Downbeating nystagmus of central origin usually observed in all positions, right, left, dexhol bike, and head extension. So if you have a case which with downbeating nystagmus limited only to one side of dexhol bike test, especially there was a torsional, small torsional component towards the left side. So most probably this is a case of anterior canal BBV. And simply you just can do a repositioning maneuver and see the response. So that case was most probably anterior canal BBV. The 142 with a small vessel disease, yeah.
Small vessel is second one.
Second one, yeah, maybe. Second one. So this is regarding this case. So because downbeating nystagmus of central origin, you will observe in all the positional dexhol bike, head extension, all. But for anterior canal, it's better observed in the contralateral side dexhol bike. So if you have a left anterior canal BBV, right dexhol bike will be positive with downbeating torsional nystagmus. Regarding the video, interesting video with torsional nystagmus on dexhol bike test, followed spontaneously by downbeating nystagmus. We just recorded similar case with the Cyclops system maybe 2 months ago. That's simply a rebound nystagmus. When you have a strong BBV, which induces a strong deflection of the copula, so at the end of the head position, there will be returning of the copula pack, which changing the endolymph flow, causing rebound and downbeating nystagmus. With any strong nystagmus, physiologically there is a rebound nystagmus at its end on the opposite direction, even in caloric. If you have very strong response in caloric testing, you expect after a few minutes you have opposite direction rebound nystagmus. So this was a rebound nystagmus, and it was a posterior canal. And the case we recorded already, all the nystagmus cleared after the repositioning maneuver. Just one more comment about the case of the one with CNS cysticercosis and epilepsy, which was in ibanotine therapy or phenytoin therapy. We see this commonly. Ibanotine toxicity causes acute ataxia, causes downbeating nystagmus. Simply in those cases, just to check the level, serum level of the phenytoin. So most of the times it's documented to be high, and the symptoms are usually cleared after gradual discontinuation of the medication. So in my opinion, that case was most probably related to the ibanotine toxicity, and it easily you figure it out by just checking the serum level and discontinuation of the medication. I can understand that is as being ENT surgeon dealing with the tumors, with sometimes life-threatening conditions, usually our ENT colleagues really, they are very concerned for life-threatening conditions. And we can understand why they rush to asking for the MRI. And it's from the current evidence, it's accepted that you do MRI for most of the cases presented with downbeating nystagmus. But practically in our experience, this is sometimes downbeating nystagmus occurs because of benign causes such as the anterior canal BBV or the new entity named apogeotropic posterior canal BBV. And the one more thing, it's common in migrainer. So sometimes with vestibular migraine patients, sometimes you can find any type of nystagmus in vestibular migraine cases. Spontaneous nystagmus, positional direction fixed, positional geotropic bidirectional bipositional nystagmus. So you can find any kind of nystagmus, including the downbeating nystagmus in mygronar. And if you follow again the patient after a few days, sometimes it's completely cleared. Downbeating nystagmus due to structural lesions usually persist, like Arnold Chiari malformation. Every time you examine the patient, every time you find the nystagmus. Just one more trick, optimal gaze position for examination of downbeating nystagmus is not the central gaze, it is the lateral gaze. Any kind of downbeating nystagmus become more clear if you ask the patient to look to the right or the left, because on lateral position, the elastic forces of the eye is the least, so it makes it more prominent. Thank you.
Thank you, Dr. Henry, for exciting this discussion on downbeat nystagmus, which is always, which was for a long time controversial, but because of this conversation, a lot of points have come out. Downbeat nystagmus, the gravity factor used to be considered when, okay. Whenever the question of downbeat nystagmus comes, the problem here is like, it's oriented vertically, so gravity will make sure that the person is immune to downbeat nystagmus. But so because of that, okay, and then lesion studies in animals, MRI studies correlating true actual known lesions of the brain causing downbeat nystagmus have been known. So the possibility of anterior canal BPP actually causing downbeat nystagmus was getting a backseat, but now there is a nice conversation. I think we have recorded most of the conversation is recorded. I request Dr. Henry to compile this full presentation of the downbeat nystagmus and the responses, so and make one final conclusion about and recommendations when you encounter a patient of downbeat nystagmus. Because what happens is, doing an MRI in everybody is not feasible. So when to do, how to do, probably I'll request him maybe a week or 2 weeks later when we are uploading everything else. If he agrees, we will put that also up also on this thing, because this downbeat nystagmus is controversial, and it will be great if he can put up everything. He has put in so much of effort into this thing. It will be great if he can put up one compiled report about downbeat nystagmus. Sir?
Sure, I'll do it. Thank you.